Welcome back to the deep dive. Today we're tackling something you'll definitely see a lot, and it's super high yield if you're prepping for exams like the MSRA. We've got some revision notes here, all focused on rosacea, our plan. Basically, pull out the absolute key things you need to know from these sources, give you a really focused overview.
Exactly. Rosacea,
Yeah.
it's more than just, a bit of redness. It's chronic. It has specific features, specific ways to manage it that you really need to get your head around. So yeah, we'll walk through the essentials from these sources, cut through the fluff.
Let's get straight to the core facts. Okay, so rosacea. Let's unpack it point by point based on what we've got here. First off, the definition. What is rosacea, fundamentally? The sources consistently call it a chronic inflammatory skin condition, mostly affecting the face.
Yeah, and that chronic inflammatory bit is crucial. It's not just blushing that goes away. The key features to look for, based on this material, are that persistent redness, the flushing episodes, those tiny visible blood vessels.
Telangiectasia.
Telangiectasias, exactly.
Yeah.
And often papules and pustules, bumps and spots. It's a long-term thing.
And it doesn't always look the same, does it? The sources mention different subtypes. That seems pretty important for figuring things out.
Absolutely critical. So you've got the papulopustular type that's redness with the papules and pustules.
Mm-hmm.
Then Erythematotelangiectatic, bit of a mouthful.
Yeah.
That's mainly the flushing, the persistent central redness, and those visible vessels. Then think Phymatous, less common, but you need to know it. That's where the skin thickens up, gets nodular. Think Rhinophyma.
Rhinophyma, the classic nose changes.
Precisely, though that's usually an advanced stage. And don't forget ocular rosacea. It affects the eyes, dryness, itching, gritty feeling, blurred vision sometimes, even inflamed eyelids, blepharitis, or the cornea, keratitis.
Oh, and there's a granulomatous type mentioned too, less common.
Wow, okay. Lots of possibilities. The sources also bring up an updated classification from 2016. Why does that matter for revision? Well, it helps structure how you assess it clinically. It's linked to these ARSCO panel criteria sometimes mentioned. Instead of just subtypes, it looks for diagnostic features like persistent redness in the center of the face or those Phymatous changes. If you see those, that is rosacea. Then you have major features, flushing spots, vessels, eye signs, and secondary ones like burning, stinging, swelling, dryness. The point is, diagnosis isn't random. It's about spotting these patterns, these phenotypes.
Got it. So, pattern recognition. Okay, we know what it is, how it looks, but why does it happen? The sources say the exact cause is, well, murky,
Yeah,
multifactorial.
right. No single smoking gun. It seems to be a mix. Genetics definitely play a role. You often see it run in families.
Yeah.
Then there are issues with the skin's immune response being a bit off, and the blood vessels themselves seem overreactive. And yes, Demodex mites get a mention.
Demodex mites. Those tiny things on our skin.
Yep. Everyone has them, but maybe in rosacea they trigger an immune response, contributing to the inflammation. It's part of that complex picture.
Beyond the biology, there's a whole list of triggers, things that make it flare up.
Yeah.
This sounds super practical for patient advice.
Oh, totally. This is high yield for you and for patients. The list includes things like age, being photosensitive, UV exposure, so sun, smoking, big temperature swings, spicy foods, alcohol, stress, even heavy exercise, and some medications.
So knowing these is gold dust for managing it.
Definitely. And specifically for flushing, the sources narrow it down. Heat, sudden temperature changes, alcohol, caffeine, spicy food, stress, sun, wind, and vasodilator meds. Knowing that list helps you ask the right questions.
Okay, it leads us nicely to risk factors. Who's more likely to actually get rosacea?
Key things to look for. Fair skin is a big one, especially if there's a family history. It's more common in women, typically showing up between 30 and 50. Lots of sun exposure is another risk factor, which ties back to the UV trigger. And yeah, those triggers, again, regularly consuming hot drinks, spicy foods, alcohol, they're listed as risk factors too.
Right, so fair-skinned woman, maybe 40s, complaining of flushing. Rosacea should be high on your list.
Exactly. Helps you build that differential diagnosis list.
Let's go a bit deeper. The pathophysiology, how does it actually work?
Okay, so the core problem is this chronic inflammation in the skin. The blood vessels dilate way too much, abnormal vasodilation, and the skin's immune system isn't functioning quite right. Think of it like the skin's thermostat and defense system being overly sensitive. So when those triggers hit sun, stress, spice, whatever, they kick off this immune response in the skin. That releases inflammatory chemicals, which then make the blood vessels widen dramatically. It becomes this cycle. Trigger, immune response, inflammation, vasodilation, leading to the redness and bumps you see. It's that chronic loop.
Ah, okay. Explains why avoiding triggers is so fundamental. Now, facial redness. It isn't always rosacea, is it? What else should be on our minds? The differentials.
Absolutely critical. You've got to rule out other things. Acne vulgaris is a big one, especially if there are papules and pustules. Also, seborrheic dermatitis, lupus, particularly the facial rash, the butterfly rash, contact dermatitis, and perioral dermatitis.
And there's a useful clue to tell it apart from acne.
Yes, a really helpful point. Rosacea skin usually isn't greasy, like typical acne. It might actually feel quite dry or sensitive. That's a key differentiator. So imagine a case. Patient has facial spots, redness, but reports dry skin. That steers you away from classic acne, maybe towards rosacea, or possibly seborrheic dermatitis.
Good tip. What about how common it is? Epidemiology, especially in the UK.
It's pretty common. The sources suggest around 1 in 10 people in the UK might have it. It's much more frequent in fair-skinned individuals, particularly those with Celtic or Northern European backgrounds. And like we said, about 3 times more common in women, typically hitting that 30 to 60 age bracket.
Oh, and an important diagnostic point from the sources, that persistent central facial redness needs to have been there for at least 3 months.
3 months duration. Okay, so let's paint a picture. What are the actual clinical features? What does it look and feel like? Well, the main thing is that persistent redness on the face, combined with the flushing episodes and those visible telangiectasias. But patients often report more. The papules, pustules, sometimes deeper lumps called inflammatory nodules. They might feel burning or stinging, skin dryness. And of course, the eye symptoms we mentioned, ocular rosacea.
And it tends to evolve, right? It doesn't just appear fully formed.
Usually, yeah. It might start subtly, maybe just occasional flushing triggered by certain things. Then over time, that can become more constant redness. The little vessels become more obvious. Some people also mention that gritty feeling in their eyes or even some facial swelling, edema. Other things you might see, prominent oil glands, that nasal enlargement, rhinophyma in advanced cases, sometimes swelling around the eyes, periorbital edema. The sources summarize the key things to look for. Central face involvement, the flushing, persistent redness with spots, bumps, telangiectasia, sensitive skin, sometimes dry scaling skin called rosacea dermatitis, and that rare severe swelling, Morbihan disease.
Morbihan disease, right? The severe edema. And triggers make all this worse. You mentioned blepharitis again with the eye stuff, shows how linked it all is.
Exactly. And it's progressive, but the severity is hugely variable. Some people just have mild flushing, others get really significant changes.
Okay, so with all these signs, what tests do we actually need? Investigations.
This is a key point for exams. Diagnosis is overwhelmingly clinical. Based on history and what you see, no specific lab test confirms rosacea itself. Now, you might do tests, but usually it's to rule out other conditions if the picture isn't clear. Maybe a skin biopsy if you're really unsure, patch tests for allergies, blood tests if you suspect lupus. But most times, history, examination, identifying triggers, that's enough.
So biopsies are only for uncertainty.
Pretty much, yeah. Not routine. And thinking about those ARSCO criteria, diagnostic, major, secondary features, that is your structured assessment. It's clinical reasoning.
Right then, the crucial bit, management. How do we treat it? Thinking about guidelines like NICE-CKS or general NHS approaches.
Okay, the goals are simple. Control the symptoms, calm down the inflammation, and stop it getting worse.
And the first step isn't necessarily medication.
Absolutely not. Lifestyle advice is paramount. Identifying and avoiding personal triggers is number one, whether it's spicy food, alcohol, heat, stress. Using gentle, water-based cosmetics. A huge don't is using topical steroids on the face. Big no-no, can make it worse. And daily, high-factor, ideally oil-free, sunscreen. Non-negotiable because of the UV link.
Okay, essential baseline advice. Then what about treatments?
For mild stuff, topicals are first line. Metronidazole cream or gel is common for the papules and pustules. Azelaic acid is another good option. If flushing is the main issue, topical bromonidine or oxymetazoline can temporarily shrink the blood vessels and reduce redness. And topical ivermectin is particularly good for the papulopustular type, maybe linked to those Demodex mites.
What if it's more severe or topicals aren't enough?
Then you step up to oral antibiotics, usually tetracyclines like doxycycline or minocycline. They work mainly for their anti-inflammatory effect here. For really tough cases, other oral meds might be tried, and low-dose oral isotretinoin is an option for severe resistant rosacea, but comes with significant side effects and strict prescribing rules. For really bad flushing, things like clonidine or carvedilol might be considered. Other anti-inflammatories like oral diclofenac or topical calcineurin inhibitors, tacrolimus, pimecrolimus, are also sometimes used.
And managing ocular rosacea specifically.
Yeah, that needs dedicated attention. Lid hygiene is key, gentle cleaning, warm compresses. Lots of artificial tears for dryness. Systemic tetracyclines often help here too. For the inflammation, definitely avoid retinoids, which can worsen dry eye, and stop any facial topical steroids.
Are there other non-medication treatments available?
Yes. Lasers or IPL are good for the telangiectasias, the visible vessels. Cosmetic camouflage can help hide redness. And referral is important to dermatology, ophthalmology, maybe plastics if needed. For severe cases, diagnostic uncertainty, or things like rhinophyma or bad eye symptoms. And for those physical procedures, vascular lasers, IPL, diathermy, sclerotherapy, cautery for telangiectasias. For the spots, maybe radiofrequency or laser. And rhinophyma usually needs referral for things like laser reshaping, surgical excision, or electrocautery.
Right, a whole toolkit depending on the specific problem. What's the general outlook? Prognosis?
Generally, it's decent with good management and trigger avoidance, but, and this is a big, but it is chronic, people will have flares and remissions. It waxes and wanes. Treatment controls symptoms, prevents complications. Getting onto it early and sticking with the plan makes a big difference.
But progression can happen, and relapse is pretty common.
Definitely. Relapse is expected. And while rare, severe forms exist, and rhinophyma is that classic example of progression. The positive note is that treatments for rhinophyma usually work well, and patients are often happy with the results, despite how it looked before.
Lastly, complications. What are the potential impacts beyond the skin itself?
This is really important. The impact on quality of life can be huge. The visible nature, the unpredictability, it causes real emotional distress, social anxiety, low self-esteem. The ocular side can lead to chronic irritation and, if severe, potentially vision problems. And rhinophyma is obviously a major physical complication if it develops.
Yeah, that really highlights why good management and support are so vital. It's not just cosmetic. Okay, so that was a pretty deep dive into rosacea, guided by those revision sources. We've covered the definition, the types, causes, risks, the mechanisms, differentials, how common it is, what it looks like, investigations, a whole range of management options, and the prognosis and complications.
Yeah, hopefully that pulls out the really high-yield stuff for you, whether it's for MSRA prep or just seeing patients. Key things to remember. It's chronic, triggers are crucial, and management needs tailoring to the specific presentation, the phenotype.
And maybe something to think about, given how much this affects people's lives, maybe the most powerful thing you can do is really partner with them to nail down their specific triggers. Could that be even more impactful than the prescription pad sometimes? Just a thought.
Absolutely. So this deep dive was about extracting those revision essentials for you.
And if you're looking for more resources,
For more free MSRA revision resources, you can always visit freemsra.com.
and for the full premium revision toolkit, check out pastthemsra.com. That's us for this deep dive. Keep exploring, keep learning.